For our first case, we have JW, who he has undergone a swallow study and was shown that he's at high risk of aspiration. He does refuse surgery and expresses a strong preference in oral feeding, even knowing the risk of serious complications or death. So, some relevant facts or values or beliefs about this case. He is a 35-year-old male with a self-inflicted gunshot wound to the neck. He only communicates using electrolarynx or eye gaze. He has aspirated on all food consistencies during clinical assessments, and he is not a candidate for video fluoroscopic study due to poor tolerance. He does refuse and states he refuses surgery and states he would prefer death over not eating by mouth. His family also understands the risks and still wants him to continue oral feeding. People in this case include JW, the patient, his family, who also supports JW and participates in his decision making, the SLP, who is involved in the swallowing evaluation, and then the medical team. So the dilemma for this case is, should the healthcare team respect JW's informed refusal and his decision to eat orally despite a high risk of aspiration, or should they override his decision to prevent medical harm? Some possible courses of action for this case would be, number one, to honor JW's decision and proceed with oral feeding under strict supervision. Conflicts that may arise with this would be risk of aspiration and possible or legal professional liability if harm occurs. Second would be to override JW's wishes and proceed with nutrition via G-tube with nothing by mouth. Conflicts that may arise with this decision would be it violates JW's autonomy, and there could be legal risks of performing a procedure without the patient's consent. And lastly, using a G-tube together with small amounts of relatively safe food consistencies taken orally. So conflicts that may arise with this decision would be legal risks of performing procedures without JW's consent and possible legal or professional liability if harm occurs. So some legal principles that are tied to this case is autonomy, which is respecting JW's informed decision. There's also non-maleficence, avoiding harm via aspiration, also acting in JW's best interest, and ensuring ethical and legal fairness. Some ASHA Code of Ethics include Principle 1, Rule B, which individuals shall use every resource to ensure quality of service. We also have Principle 1, Rule G, which individuals may not impose treatment that is not in the client's best interest. Principle 1, Rule H, individuals must respect the autonomy and rights of patients to make informed decisions. And lastly, interprofessional relationships must be based on mutual respect. For our proposed course of action, we chose to honor JW's decision and proceed with oral feeding under strict supervision. So some of the social roles would be the SLP as an advocate and safety monitor for this decision. We also have the family as the support and surrogate voices, and then the physician as the prescriber and medical decision maker. So some of the self-interest would be the liability and reputation of the SLP. We also have the medical teams or the institution's concern for patient outcomes and legal safety. And then we also have JW's quality of life preferences. So we do believe that this ethical scenario can come to a consensus if the healthcare team recognizes JW's autonomy and that they proceed with oral feeding with close monitoring and a palliative/supportive care team. It's also in their best decision to have some kind of waiver that JW signs or his family signs, letting documentation saying that he understands the risks, that he's been told the risks, and he still wants oral feeding. Possible sanctions could be a suspension or revocation of of the SLP certification, legal liability in the case of harm, and then suspension or revocation of the state license for unethical practice. Our second case study is BJ. BJ is a 9-month-old that was diagnosed with a progressive and terminal condition. He has had multiple pneumonias and inadequate oral intake. The medical team recommends a G tube, but the mother does not want an NG tube or a G tube. She wants palliative care to reduce suffering and values comfort and avoidance of suffering. The medical team values preservation of life and nutritional adequacy. So the key people in this case is BJ, the infant patient, the mother, who is the surrogate decision maker, the medical team, the palliative care team, if it is consulted, and state child protective services if disagreements in the decision escalate. So the dilemma is, should the medical team honor the mother's decision to refuse a G-tube and prioritize comfort care, or should they insist on a G-tube to prolong the infant's life? So some possible courses of action for this case would be to first honor the mother's decision and transition to palliative care, allowing the child to die naturally and comfortably at home. Some conflicts that may arise with this decision would be it perceived as giving up on life-sustaining treatment, or legal questions if death occurs soon after withdrawing of feeding. The second would be to override the mother's decision and seek legal or ethical intervention and proceed with the G-tube to extend BJ's life. This would violate the parental autonomy and wishes and may cause unnecessary suffering to BJ. Also, the third one could be to provide NG tube feedings. This also does violate parental autonomy and wishes. And the last possible course would be to have intervention by an occupational therapist or speech therapist to facilitate oral feedings. This again does violate parental autonomy and wishes and may cause unnecessary suffering in a terminal infant. So some ethical principles tied to this case would be respecting the mother's decision-making on behalf of BJ, her autonomy, acting in the infant's best interest, which may include comfort-focused care, avoiding interventions that prolong suffering, and ethical consistency in care of a terminally ill child. Some ASHA Code of Ethic principles include respecting the autonomy of clients and their families in decision making, providing services that are best in the interest of the patient, and interprofessional collaboration and respect. So we decided for the proposed course of action would be to honor the mother's decision and transition to palliative care. So the social roles, the SLP that assesses the swallowing and communication findings would advocate for comfort. The mother is the legal guardian, with being the surrogate decision maker, and then the physicians, which are responsible for medical recommendations. So self-interest in this case would be the SLP having the desire to protect the infant from aspiration and discomfort. We also have the medical staff to avoid liability, and then the mother that's wanting to reduce her child's pain and ensure a dignified death. So this ethical scenario could reach a consensus if they have an ethics consultation really focusing on comfort, family autonomy, and the quality of life in a terminal case. Going about it the right way would lessen the possibility of sanctions, which include the reprimand or suspension of certification. There's could be internal disciplinary actions, legal risks if interventions are performed without the mother's consent, and license suspension for ethical violations. For our third case, we have AD, who is a 20-year-old male that has severe cognitive impairments and is unable to follow treatment directions. So he does aspirate on thick liquids and has insufficient clearance with purees. He is fed orally and shows that he enjoys food through expressive pleasure with smiling and laughing. He has lived in the same foster home for 8 years, so switching to tube feeding would require him to move to a different foster care setting. Due to this, the foster family does oppose feeding tube placement due to forced relocation of AD. The court-appointed guardian has no prior relationship or trust with AD. The foster family does value his quality of life and his emotional well-being, while the medical team does value health preservation and prevention of aspiration. And then it is shown that AD does demonstrate joy with eating, reflecting through his pleasure-based value of oral feeding. And then the state values compliance with care standards related to feeding tubes and supervision. So the key people in this case include AD, the patient who is nonverbal and cognitively impaired. We also have the foster family, who is his long-term caregivers who know AD the best. We also have the court-appointed guardian, which is technically the legal surrogate but has no prior relationship with AD. We also have the SLP and medical team, and then the state agency that governs the foster care system and placement standards. So the dilemma in this case is, should the medical team prioritize AD's medical safety through feeding tube placement, resulting in a removal from his current foster home, or should they prioritize his quality of life and emotional well-being by continuing oral feeding despite aspiration risks? So possible courses of action for this case would be to first have the G-tube only and having nothing by mouth. So conflicts that may arise with this decision would be, it does remove pleasure from feeding for AD. It does require transfer to an unfamiliar care setting, and could cause emotional trauma and disruption to AD. The second course would be to have a G-tube and small oral feedings for pleasure. Conflicts that arise, it still may require relocation from his foster family. Third would be an NG tube and small oral feeding. So this would be basically the same thing, but it would be temporary and may reduce the risk of aspiration without permanent placement, but still might require a new foster care placement. And then lastly would be to continue with oral feeding with close monitoring. This conflicts that may arise with this decision would be higher risk of aspiration. So ethical principles in this case, we have considering AD's overall welfare, including his emotional and social well-being. We also have avoiding physical harm of aspiration or malnutrition. We also have autonomy, so respecting the insights and relationship of the foster family. And then justice, equal access to appropriate individualized care. Some extra code of ethics, we have Rule H, respect for autonomy. Rule G, only providing services in the client's best interest. And Rule E, respecting and collaboration with other professionals and caregivers. So, AT's case study is probably the trickiest case study out of the three. We did pick the proposed course of action being a G-tube with small oral feedings for pleasure. Social roles in this action would be the SLP for recommended safe feeding and advocate for quality of life. We also have the foster family, the guardian, which is the legal authority in this case, and the state, which will establish the placement rules. Self-interest, the foster family wants to continue caring for AD in their home. The state wants to meet medical standards and limit liability. And then the medical staff wants to balance safety with ethics and legal compliance. So a consensus on this case may be tricky. I think the biggest thing is trying to have some kind of documentation, a special waiver, appeal, anything that would allow AD to continue placement in his current foster home, to have the G-tube but small oral feedings. Possible sanctions could be potential liability if the decision leads to harm. Disciplinary action for not following policy with the small oral feedings for pleasure, investigation, and possible suspension or revocation for unprofessional conduct.
So for scenario number 2, we are looking at Susan, who's an English-speaking monolingual SLP, who is treating Joseph, who's a 6-year-old Spanish-English bilingual student. Joseph was referred to Susan by his teacher due to concerns about potential stuttering, but due to the fact that Susan does not speak Spanish, she attempts to refer him out to another bilingual SLP in the district, but her request is denied due to the caseload of the bilingual SLP being above capacity at the moment. So the relevant facts, values, and beliefs of this scenario is that Susan is monolingual and does not speak Spanish. Joseph is bilingual and was referred due to concerns of potential stuttering or a fluency issue, and he's unable to be transferred to a bilingual SLP due to current caseload capacity. There is a high risk of stuttering misdiagnosis for bilingual children due to the high rate of mazes that they use in their speech, so that is an important fact to kind of keep in mind as we move through this scenario. The key people are Joseph, who is the client, Joseph's parents, who have the right to deny any assessment of their child or enrollment in special education, Susan, who is Joseph's SLP and will be the one making assessments and diagnosis regarding his stuttering, the school staff, such as the teacher and the instructional support team who referred Joseph to Susan, and the interpreter who was being used to contact Joseph's parents and kind of helping with the Spanish parts of the assessment that need to be completed. The dilemma is that should Susan use her resources to assess Joseph due to concerns of stuttering, despite being unable to speak Spanish, thus increasing the risk for an inaccurate diagnosis? So some of the possible courses of action for this scenario would be to, 1, use available resources to assess and diagnose Joseph for stuttering concerns. But some of the conflicts that may arise with this is that Joseph could be misdiagnosed due to the fact that Susan does not speak Spanish and cannot complete his assessment for his fluency in Spanish, as when a bilingual student is showing fluency concerns, there needs to be fluency concerns in both languages to be considered an actual fluency disorder. And also, parental autonomy and wishes may be violated due to a language barrier, as in the scenario it was stated that it was very hard to start contact with Joseph's parents, and it required an interpreter to kind of start that process and have them start responding. The second option would be to wait until the bilingual SLP's caseload is reduced and Joseph can be transferred. But with that, Joseph may have to wait longer for treatment due to unpredictable timeline of when the bilingual SLP would have space, or Joseph's parents could lose trust in the schools due to the request to transfer. Some of the ethical principles to keep in mind for this scenario is autonomy and respecting Joseph's parents' right to deny assessment and enrollment in special education, as well as acting in the best interest of Joseph to ensure he has access to resources that will produce an accurate assessment and treatment plan. There are 3 codes of ethics listed here. We have Principle 1, Rule H, respecting the autonomy of clients and their families in decision making. We have Principle 1, Rule G, providing services that are in the best interest of the patient. And Principle 4, Rule E, interprofessional collaboration and respect. So, for this scenario, the proposed course of action is that Susan will complete Joseph's assessment using resources available to her and try to request a second opinion from a bilingual SLP in her district. The reason that this is the proposed course of action is to ensure that Joseph is getting the assessment and making sure that the steps are being started. And hopefully, in the meantime, maybe a spot will open up with the bilingual SLP or something like that. But just kind of get the ball rolling on the assessment and outsourcing to get information and resources from other SLPs. The social roles in this scenario is that the SLP Susan will be assessing and diagnosing Joseph using resources provided to her. The parents are entitled to autonomy regarding the assessment, treatment, and enrollment of their child in the special education programs, and the teacher and school staff are responsible for managing and making note of observations and referrals in the classroom. Self-interests, the SLP is looking to kind of maintain professionalism and do what's best for the student with what she has available to her. The parent is trying to maintain the best interest of their child during the assessment process, and the teacher and school staff are looking to ensure all legal components of the referral and assessment are taken into account. A consensus might be reached through a parent-teacher conference, presenting assessment results, options for treatment, next steps regarding special education enrollment if applicable, and kind of just giving them an overview of what the next steps will be and kind of what each step will look like moving forward. And possible sanctions could be internal disciplinary actions and license suspension for ethical violations. Moving into scenario number 3, we are looking at Marie, who has been working with her client Patrick for the last 3 years to improve his stuttering, but throughout treatment has noticed a lack of progress and is worried she is unable to effectively treat him anymore. She decides to move forward with a request to transfer Patrick to a different SLP who is specialized in the treatment of stuttering, but her program director denies her request and says it's inappropriate. So the relevant facts, values, and beliefs of this case is that Marie feels that she has done all that she can do to treat Patrick and worries she's not capable of making any more progress with him. And she feels that a more specialized SLP would be more effective for him. Marie's program director feels that the request is inappropriate and that Patrick should not be transferred. So the key people in this scenario are Patrick, who's the client, the parents who have the right to deny any transfer of services of their child, Marie, who is Patrick's SLP and responsible for ensuring he receives the best possible care, and the program director, who is Marie's boss and is able to deny permission for certain requests. So the dilemma is, should Marie follow through with her transfer request despite her program director's denial, or should she use resources available to her to continue treating Patrick? So the possible courses of action for scenario 3 are to 1, follow through with the transfer request despite her program director denying her request, which could lead to her receiving disciplinary actions due to not following her program director's instructions, which could be termination. Or she could lose Patrick's and his parents' trust due to deciding not to treat him anymore. Or 2, she could continue to treat Patrick despite not seeing any progress and try to improve her knowledge of stuttering treatment plans. This course of action could lead to Marie being in violation of ASHA's code of ethics by not providing services that are in the best interest of the student, and Patrick could lose valuable time not making progress with Marie if he does not get transferred to an SLP that is specialized in stuttering. So the ethical principles here are respecting Patrick's parents' right to deny transfer requests, as well as respecting Patrick's autonomy, and acting in the best interest of Patrick to ensure he has access to all resources regardless of cost. So the code of ethics principles that are listed here are Principle 1, Rule H, respecting the autonomy of clients and their families in decision-making. Principle 1, Rule B, individuals shall use every resources, including referral and or interprofessional collaboration when appropriate to ensure that quality service is provided. Principle 1, Rule G, providing services that are in the best interest of the patient, and Principle 4, Rule E, interprofessional collaboration and respect. So, the proposed course of action for scenario 3 is that Marie will speak with her program director regarding the complexities of stuttering to discuss the reasoning behind the transfer request, as well as organize a meeting with Patrick's parents and Patrick to discuss treatment options. So, the social roles for the scenario are that the SLP Marie will organize the meetings to discuss treatment plans with her program director, Patrick, and his parents. Patrick's parents are legally entitled to autonomy regarding their child's treatment, and Patrick is entitled to autonomy regarding his own treatment. The self-interests in this scenario is that Marie must uphold Asha's ethical considerations and ensure she is doing what is best for Patrick and his treatment. The parents of Patrick are maintaining the best interests of their child to ensure that treatment has the best possible outcome, and Patrick must maintain autonomy in his own treatment and make decisions that he feels will be beneficial for him moving forward. A consensus for this scenario may be reached through a meeting with Marie's program director to discuss the complexities of stuttering and request for the transfer to be approved, as well as meeting with Patrick and his parents to discuss her reasoning for the transfer request and discuss Patrick's speech at home. Possible sanctions for this scenario could be internal disciplinary actions, such as her being terminated, or license suspension for ethical violations.